Hi, I'm Max. Let's talk about evidence-based medicine. So why do we use evidence? Well, learning is a biological process. People are going to learn with or without being taught. In the absence of proven true information, we tend to come up with our own individual explanations for how the world works. Evidence is the result of a systematic process of discovery. It's a way to make sure our explanations reflect how the world really works. That systematic process is the scientific process. It's a way to gather information while reducing the natural bias that comes with being human. But hold on, scientific process? Isn't that for scientists? Tactical medicine is just about the furthest thing from lab coats and beakers, right? Well, the UK Science Council defines a scientist as someone who systematically gathers and uses research and evidence to make hypotheses and test them, to gain and share understanding and knowledge. They go on to say that all scientists are united by their relentless curiosity and systematic approach to answering questions. That sounds like just about anyone can be considered a scientist as long as they're using a systematic process to gather information and reduce error. So going back to the scientific process, gathering information while reducing error, what is it? Well, medicine is a science. We're constantly faced with the question, what can we do better? And the answer to this question may come from simply looking at what other medical scientists have reported, or it may require further study. We can then come up with a hypothesis, a tentative explanation which is both testable and falsifiable. This is where a lot of people stop, satisfied with their own untested explanation of how things work. But this is not the end. We must then go on to test our hypothesis. A scientist defines the methods, how they're going to test their hypothesis, defines their controls and ways to reduce bias, and then specifies the data that they want to collect. After we analyze our data, we can then interpret them and come up with a conclusion. Our conclusion may be practice-changing, but it's more likely that it's one more step in the progress of science. We can then add our voice back to the community of scientists going through the same process of asking questions and finding answers. We can do this through publication. However, there is a huge specter hanging over this whole process, and that is bias. Bias affects how we construct our hypotheses, how we collect our data, how we analyze those data, how we interpret our analysis, and how our conclusions are presented back to the scientific community. So why is bias important? Bias is any trend or deviation from the truth in data collection, analysis, interpretation, and publication, which can cause someone to draw a false conclusion. Bias can happen either intentionally or unintentionally. Intentionally biasing research is obviously immoral and may lead to disgrace if you're lucky or unemployment if you're not. Bias can generally be grouped into 4 categories. Hypothetical or methodological errors, these are asking the wrong questions. Data collection errors, these are measuring the wrong things. Errors in data analysis, this is doing bad statistics. And errors in interpretation or publication, this is making bad conclusions. Now, I think it's important to note here that every study has limitations, especially in tactical medicine, where most of our data are collected retrospectively. There are confounding factors and effects that are sometimes impossible to eliminate. So why is all this important? Well, bias is the interpretation of information in favor of one fact over another. The scientific process attempts to control for bias, but let's go through some of the forms of bias. And this is by no means an exhaustive list of potential biases, just some of the more common forms that I've run into. In the methods section, we have control groups, sample size, and blinded testing. Control groups. In clinical trials, a control group is one that doesn't receive the treatment. Test subjects are compared to the control group to determine objectively what effect has occurred. Sometimes it's not possible or even unethical to have a control group, but not having control groups limits the strength of the study. Sample size. The fewer the people studied, the less probable that the study represents a broad population, and the less a conclusion may be applicable. However, large studies are expensive, and smaller studies can be grouped together in meta-analysis later down the road. Blinded testing. Blinding is a way to avoid the false perception of cause and effect by withholding information that may influence behavior. By blinding the treatment groups, we avoid the placebo effect, and by blinding the providers, we prevent any alterations in care. However, it can be impractical to perform blinding on all studies, especially when the treatment effects are obvious. Under metrics, we have exclusion of data and p-hacking. Exclusion of data, also known as cherry picking or sampling bias, is the inclusion of data that will support your hypothesis or the suppression of data that may not confirm your desired outcome. P-hacking is also known as data dredging. This is the manipulation of statistical analysis to find patterns in the data that could be presented as statistically significant. This can be accomplished by performing a lot of different statistical tests on the data and only reporting the ones that show promise. Under meaning, we have correlation versus causation, unsupported conclusions, conflicts of interest, and peer review. Correlation versus causation. It can be easy to make associations between cause and effect. Correlation is an observed relationship or a pattern between two values. Causation is a direct link between those values, which can only be determined through an appropriately designed experiment. For example, in a certain city, crime increases as ice cream sales go up. It could be easy to make the connection between these muggings and the sale of ice cream cones, or there may be a missing variable. In this case, as the days become warmer, both ice cream sales and crime rise. Just because two things happen in sequence doesn't mean that one caused the other. Unsupported conclusions. Supposition can be the driving force behind science, but conclusions need to be based on fact. Any conclusion that is reached needs to include the major findings, and any discussion should apply those findings to current practice or future research. Bad conclusions can hurt people. Conflicts of interest. Research can be misinterpreted for financial or personal gain. A conflict of interest, or COI, is when there's potential or actual compromise of the scientific process to create a bias. COIs are often required to be disclosed in publication, and you should maintain a healthy skepticism of data funded by the companies poised to profit from its favorable interpretation. Peer review. Peer review is an important part of the scientific process. Other scientists will critically evaluate your work and then suggest corrections before it's released to the public. Just because a magazine has the word journal in the title doesn't necessarily mean it contains scholarly peer-reviewed science. So how do we use this evidence? Evidence-based medicine, or EBM, is the careful, clearly developed, practical, and logical use of modern best practice in decision-making about the care of an individual patient. EBM developed as a reaction against poorly designed observational treatment research and physician reliance on personal experience with other patients. And it relies on three things to be successful: the best available evidence, gathered through sound scientific practices and carefully evaluated for relevance by all providers; provider judgment and experience, also called Gestalt, built up through years of successful relevant practice with sufficient volume; and individual patient needs and requirements at hand, whether it's the specific acute processes of a traumatic injury or the restrictions on care created by someone's medical history, such as allergies, or values, such as certain religions preventing blood transfusions. When providers fail to engage all three aspects of the EBM triangle, they create the potential to deliver inappropriate care. Empirical treatment is based on the provider's observations of other similar patients. Observations are a form of evidence and are the beginning of the scientific method, but there is a lot of work to be done before a conclusion can be reached from one experience translating to another. However, while empirical treatment is educated guesswork, it is not inherently bad. Sometimes, in the absence of good evidence, we have to use focused empiricism to do the best we can until evidence suggests that we change our practice. This is especially important in the unique field of tactical medicine, where evidence is difficult to collect. Hasty or routine application of protocol, which is broadly applying interventions without consideration of the unique aspects of each individual patient's situation. This creates opportunities for inappropriate care. For example, if we say that all X patients will get Y treatment, we may apply a treatment inappropriately. So, for example, any patient meeting SIRS criteria will get a 30 cc per kilogram saline bolus. Without looking at potential comorbidities in this patient, your blind application of protocol could result in causing more harm. Now, hasty treatments are required for perceived life-threatening conditions. Especially in tactical medicine, the sequence for identifying and treating causes of preventable death should be automatic and rapid. However, once you enter a more stable tactical situation, you should be equal parts tactician and clinician. Unsuitable training and exposure. Successful providers have access to patient volume, the specific types of patients that they expect to treat, and a program that supports their development. In the context of trauma, low appropriate patient volume, such as working in an rural emergency room, high volume of non-appropriate patients, such as working in a non-emergency clinic, and programs that don't emphasize a review of appropriate cases all contribute back to decreased provider experience and expertise. In the military, we often place our most junior and least experienced providers far forward, and then require them to manage complex battlefield trauma, far from consultation, mentors, and specialists. When they're not in combat, they rarely have access to the types of trauma that they're expected to see. Because of this, tactical medics in the military tend to have a remarkable lack of experience. Compressed training timelines don't help in the building of quality, competent providers, especially the kinds of training whose primary objective is to renew certifications. Not every organization is going to have the access to the best available evidence, the volume and types of patients needed, and the consistent training to bring it all together. However, it's important to recognize where the gaps are in an organization to be able to fix or compensate for them. Only when all three components are in balance are you truly practicing evidence-based medicine. So what evidence do we use to fuel our evidence-based medicine? Well, we use strong evidence. Any experiment that suggests a relationship between two clinical variables constitutes some form of scientific evidence. The strength of that evidence is determined by the methodology used to collect and analyze the information, the total number of measurements made, the degree of any correlation observed, and then the ability to reproduce the results. The strengths and weaknesses of different types of studies place them in a sort of scientific pecking order called the hierarchy of evidence. This is also sometimes called the levels of evidence. This hierarchy describes studies based on their methodological quality of their design, the validity and applicability or generalizability to a larger patient population. This hierarchy sorts sources of data into two general categories: filtered information and raw information. The highest levels of evidence involve the filtering and consolidation of information. These products are usually the most reliable in their conclusions and recommendations. Systematic reviews and meta-analyses gather data from previously published sources and combine them to create large data sets. As we discussed, the larger the population studied, the more likely the conclusions will be reliable. However, some things can't be studied by meta-analysis. In 2003, the British Medical Journal published a joke article in their Christmas edition, which reviewed studies looking at parachute effectiveness. The study authors defined their search methods, they defined the databases that they were going to use, and the main outcomes they were looking for to determine whether parachutes were indeed useful when jumping from high places. But, as it turns out in 2003, there weren't many people willing to jump out of a plane without a parachute, so no studies were found. Guidelines and protocols are generally written based on the current best practices in a given area and are informed by up-to-date evidence. However, they often lack the typical structure of a scientific report, which makes them more useful for day-to-day clinical practice, but less reliable as a source of scientific information. Article reviews and synopses may be generated by organizations or individuals and attempt to place the results of a study into the context of clinical or operational practice. However, unless great care is taken in their preparation, there's a significant opportunity for bias. Unfiltered information. The next group of evidence levels involves raw information from well-constructed studies. A well-designed study is constructed to remove potential bias and powered to show a statistically and clinically significant result. Collectively, these may be reviewed for meta-analyses or systematic review later. An example of this is the randomized controlled trial, or RCT. These are prospective clinical studies designed to minimize bias by randomly putting study participants in 2 or more treatment arms, often blinding the patients and the investigators to which arm they're in. By randomizing and blinding, this methodology is pretty effective at preventing intentional or unintentional influence. However, some things can't be studied by RCT. In 2018, again, the British Medical Journal came through for us with an RCT of parachute effectiveness. They built 2 treatment arms, jump from a plane wearing a parachute and jump from a plane wearing an empty backpack. Surprisingly, 23 of the 92 people that they asked were willing to participate, and they found a 0% difference between the groups in terms of injury. Mostly because the plane was parked on the tarmac and the average fall distance was about 0.6 meters, or about 2 feet for the Americans. This study pointed out in a humorous manner that while RCTs are considered to be the gold standard of research, we still have to pay attention to how these studies are conducted and the methods used to determine the data. Cohort studies are types of observational research that can demonstrate important associations between exposure and disease or risk factors in outcomes. These studies can either be prospective or retrospective and typically observe large groups of individuals. Case series and case reports constitute the lowest quality of evidence on the overall hierarchy because they're inherently retrospective in nature and may not feature a control or comparison group. They're usually narrow in scope, describe a single population or subgroup, and are often based on the experience of an individual researcher or a single institution. Also grouped in the raw scientific data, but not often considered, are in vitro and animal studies. These are studies performed on animals or in a laboratory setting. Because of the nature of these experiments, the results may indicate some useful biological or biochemical trends, but may not be directly applicable to human medicine. The lowest form of evidence, expert opinion, is not considered data. However, evidence from the opinions of authorities or reports from expert committees may still provide important insight into problems. Now, there are some problems with this model's stratification of the levels of evidence. Systematic reviews and meta-analyses aren't the end-all be-all of science, nor does an RCT always represent the best available data. All data need to be interpreted with the scientific process in mind and with a keen focus on preventing possible sources of bias. So what I'd like you to take away from this presentation is that you should be a smart consumer of information. You need to be able to keep in mind the scientific process and potential sources of bias when you're evaluating studies for inclusion into your practice. We should all be maintaining a clinician's mindset. The days of emergency medical technicians merely following a set of protocols and blindly applying protocols without considering the other components of the EBM triad are quickly coming to a close, as we find that we are not delivering the types of medicine that the community requires from us. So maintaining a clinician's mindset and being aware of additional points of data and variables that may affect your treatment for an individual patient is very important. And it's important to follow that up with, you need to work within your limitations. Especially as pre-hospital providers, we aren't given the level of education that our licensed oversight has. So mid-level providers such as physician's assistants and medical directors who are physicians with residency and fellowship training, they have a vast wealth of knowledge and are able to connect together points of data that we may not be able to just based on our lack of baseline knowledge. So while it is important to maintain that clinician's mindset and to know when to incorporate new evidence into your clinical practice, it's also important to understand that we have a responsibility to adhere to the protocols that are approved by our physician medical oversight. That said, you are always encouraged to engage your medical director in conversation about things that you think are important to your clinical practice. Your conversation with your medical director could be the conversation that gets a new protocol introduced in your system that could eventually save a life. So it's incumbent upon all of us to maintain that clinician and science mindset in order to deliver the best medicine that we can. Thanks.